Today we will be conducting a pulmonary assessment of the patient. To begin, we'll have our patient raise her arms, and we will assess the ratio between the anterior-posterior diameter, that is, this space, and her transverse diameter of her chest, this space. And roughly eyeballing this, Lorianne's thoracic ratio is about 2 to 1. That is, her transverse diameter is twice the length of her anterior-posterior diameter. Go ahead and put your arms down. While the patient had her arms up, we also had a good look at the composition of her chest wall. As we can see, Lorianne's chest wall was morphologically normal. While inspecting, we should also visualize the location of her scapulae or shoulder blades, which are clearly visible here and are also morphologically normal. Next, you need to inspect the patient and observe their breathing habits. Note the patient's posture and the use of any accessory muscles in the act of breathing. You also want to assess the rate, rhythm, and depth of the work of breathing. Lorianne's rate and rhythm are both normal, and she has an adequate depth of breathing. We can see her chest rise and fall with each breath. Next, we need to palpate the anterior and posterior chest wall for any lesions, tenderness, or masses. To do this, we'll have the patient raise her arms. Okay. And you can feel the intercostal space between each rib as you palpate. Okay. Now we'll have our patient turn around. We'll palpate the chest wall in its anterior aspect. And Lorianne's chest wall shows no evidence of tenderness, lesions, or masses. We will now palpate the patient for tactile fremitus, as well as chest excursion in the anterior aspect. Lorianne, when I place my hands on your chest, I'll have you say 99, and then I'll move my hands down your chest. I'll have you repeat that. Okay?
Okay. 99, 99, 99, 99, 99, 99, 99.
Okay. And here around the 10th rib near the xiphoid process, move that a little bit. Okay. Go ahead and breathe deeply. Okay. You can exhale. Okay. In testing for tactile fremitus, you're looking for vibrations as the patient speaks. These vibrations are most clearly felt near the top of the chest and typically absent at the bottom of the chest, which is exactly what we found in Lorianne's case. By placing the hands along the 10th rib with the thumbs parallel to the xiphoid process and having the patient inhale, we can visibly see an expansion of her chest as we watch the hands move and separate symmetrically with her breath. Palpation for tactile fremitus and chest excursion are both skills that should be done both anteriorly and posteriorly. Lorianne, when I place my hands on your back, I need you to say 99. I will lower my hands down your back, and I'll have you continue to repeat that word. Okay?
Okay. 99. 99, 99, 99, 99, 99, 99.
And breathe deeply, please. Okay. Again, Lorianne has tactile fremitus in the upper portions of the lungs, which is normal. It's absent in the lower portions of the lungs, which is also normal. And her chest excursion is symmetrical as she breathes in. Chest excursion is again assessed near the 10th rib by placing the hands parallel with the thumb's midline. And pinch a little bit of skin in between the thumbs, and then have the patient inhale. You should see that chest expansion again, as we did in Lorianne's case, and normally it should be quite symmetrical. We will now percuss the patient's anterior and posterior axilla. This is done with the patient's hands above the head. Thank you. Okay. Percuss, striking the knuckle. Okay. Please turn all the way to the other side. Next, we'll percuss for diaphragmatic excursion to see how far the diaphragm is moving up and down. Lorianne, I need you to exhale all the way and hold your breath out. I will be percussing as quickly as possible. Okay. Go ahead and take a deep breath in. And some normal breaths. It's important to let the patient breathe in between diaphragmatic excursion tests. Lorianne, please take a deep breath in and hold it. Okay. By marking the 2 points in diaphragmatic excursion testing, you can later measure it and determine how far the diaphragm has risen and fallen. You place your markings where you detect dull notes in percussion. Lorianne's diaphragmatic excursion is about 3 centimeters, which is normal. Lastly, we will auscultate the breath sounds of the lungs in all lobes, both anteriorly and posteriorly. Take a deep breath, please. Again. 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 And again. Once more. And we'll repeat that process on the other side. Deep breath. We will now auscultate the back of the patient's chest. We've already listened to her breath and lung sounds in the anterior and lateral aspects of the lungs, so we'll just be auscultating the back. Deep breath, please. Again. 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 And again. Deep breath. Again. And again. Once more. And one last time. Having listened to all of Lorianne's lung sounds in the front, back, and sides, I can clearly determine she does not present with any adventitious breath sounds, no rales, wheezes, or rhonchi. This has been our pulmonary assessment.